Good afternoon, and thank you for joining today's webinar. I am Sherilyn Francis with Diabetes Health Equity, PDHE. We welcome you to today's webinar, Collaboration for Diabetes Health Equity webinar series. We invite you to connect with us at www.diabeteshealthequity.org, and we will be live tweeting during today's event. You can tweet us at P4DHE using hashtag BeatesCollab. The terminal learning goals for today's activity are to reduce the risk factors that contribute to diabetes, to reduce the complication of diabetes, to reduce hospitalization and emergency stay for people with diabetes, to improve medication adherence, improve patients' quality of life and satisfaction with diabetes prevention and management programs, as well as the satisfaction of those who care for them, to provide individuals with self-management support, to improve the satisfaction of professionals within daily clinical practice, and to improve the health of the population. In compliance with ACCME guidelines, today's presenters have no financial or other relationships with manufacturers of any commercial service discussed in this educational activity. I now present to you Ms. Sabrina Jackson.
Good afternoon, everyone. Thanks so much, Sherilyn, for that wonderful introduction. As always, those of you that attend our webinars, you know that, of course, I'm excited. But I'm particularly excited today as we have the opportunity to share with you about our National Learning Collaborative. And so I'm just going to advance a little bit more through this, knowing that the cornerstone of PDHE are learn, share, and connect. And so I wanted to just start it out by framing the issues, or framing sort of what we did over this last 15 months. Today's time together will really be a cursory view. We have 3 of our 6 partnership teams that will be sharing today, and then 3 more will come back next week. So between the time of September 15 through December 2016, we hosted and we mentored 10 partnership teams through a National Learning Collaborative. It was based on the IHI Breakthrough Series model of collaboratives that you see a drawing of before you. But our idea was framed around these 3 elements. And so we realized, which I'll get into a little bit more in a little bit later, but we realized that in order to have this kind of initiative, to take our teams through an intervention of this sort, that we needed to help them build some capacity. And so the first thing that we needed to do was, as you public health professionals out there would say, is to help our teams form what we call an equity lens. So in order to look at health equity, you first need to define the inequities that are existing in your patient population, and that are the root causes of the disparities that you see in their disease processes, but also in their outcomes. This diagram, to me, does a really good job of displaying some of the drivers that our teams worked around. So a patient's health potential has many things that make it up or that can impact it. Things that you see on this slide, so access to care, the social determinants, which food and housing can be a part of, policies, something that we ended up looking at later on in the collaborative, and things like racism, to be quite frank. Many times for our patients, their health behaviors are the ones that are identified easier. But we know that as we've worked through this, and many of you out there who are listening know that there are many things that impact the outcomes that our patients face. And so the 3-element model, as we have framed it, is this idea of creating a care system that involves 3 critical areas for our patients: the clinic, the home and the community, and outcomes. We like to say around here that patients are free-range humans, and they don't live in our exam rooms, which are fortunate and both unfortunate. And so the concept that we propose with our teams that we brought together is, can we continuously improve the interventions in each domain? So can we help our teams get really good clinical care? And can we really help our community organizations do what they do really well? And then can we identify data that is necessary for us to work out of and work with? And then can we create these rapid cycle feedback loops so that each element that is represented on this screen can work together. And this slide sort of talks about where we helped our teams build capacity. We wanted them to look at how they were doing their clinical care and begin to create and do things better is the way that I'll say it to be politically correct. But things like develop and design diabetes group visits, create a diabetic registry, or start to do panel-based care management. Some ideas in the community is self-management education. There were still some teams that we work with that were not yet having formalized diabetes self-management classes. Can you work with partners to form a community diabetes coalition? And then, of course, outcomes, beginning to identify data that is in your community or that you have access to and that you can begin to use to not only diagnose what the problems are in your community, but also learn to use it in a meaningful way to show you that what you're doing is actually working. So we had them to do inside the silo improvements and then manage the in-betweens, which is where we spent the bulk of our time, to be perfectly honest. Can we work around creating a clinic community interface? So if you're having a diabetes group visit, is it possible to now conduct not just a class, but also a group visit in a community setting, maybe in the basement of a church or at a YMCA? Can you have a clinic outcomes interface where you're having EHR-generated reports on your diabetes panel and your clinical teams are learning to read these reports, all the members of your clinical team, not just your providers, and then make decisions on making changes based on what these reports are showing? And then finally, we wanted them to work around creating processes that were community outcomes interface. So organizing stakeholder groups or health equity coalitions that were committed to improving outcomes. And it looks so simple listed here on this chart, but I can promise you this turned out to be more than a notion. Can we help our teams that included clinical entities create and attend listening sessions where we get the community together and we find out what matters to them, where we give them the data that we're collecting on their community and see how they feel about it and where they would like to partner with us to work. And then this slide tells us about the model for improvement, which is the methodology that we use that was developed by the Institutes of Healthcare for Healthcare Improvement, or IHI. The model for improvement taught us to ask and answer two questions. One is, what are we trying to accomplish? And so each team was challenged with creating aims, some specific aims that they had that they wanted to accomplish together. And then how will we know that a change is an improvement? And that meant that we had to create measures. I know that all of you have been victims, or you've experienced, maybe that's a better way to say it, of us making changes that have not been tested. And so our teams needed to come up with what we call change ideas, or we gave them what was called change ideas. And that answers the questions of what changes can we make that will result in improvement. We developed these change ideas based on best practices that were identified and through a literature search, but also that was harvested through a Together on Diabetes initiative that was sponsored through the Bristol Myers Squibb Foundation. And so we took these change ideas and we gave them to our teams, and we helped to teach them processes that they could test. And then, of course, now that I'm saying testing, that's a nice segue for us to talk about the Plan, Do, Study, Act, or PDSAs. Many of us who are clinicians were not trained to do business this way. And so we spent time teaching our clinicians as well as our community partners on how to test ideas before implementing changes. And so you would do a small tested change with just a few patients, or maybe just on one day of the week, and study that to see if it's working before you spread it and finally before you implement it. So a lot of time was spent on helping our teams build capacity in order to create care systems that could function this way. And so we thought what we do today is to get together and have our teams share a little bit about their journey with capacity building. Now, those of you that are out there that are attending this webinar, you know all about how challenging it could be for someone to come to you and say, hey, on Monday we're starting this. And you also know the frustration that you feel in not knowing what to do or really how to get there. And so this collaborative was really designed to create an environment that people could learn safely. It involved a lot of peer sharing and peer learning. We learned from our failures as well as from our successes. And so we thought it'd be a great idea to have our teams share with you today a little bit about their perspective. So today we have 3 teams that have agreed to join us. It's Team Hunterdon, and they're from Hunterdon, New Jersey. We have Sandra Grinsey, and Sandra, I always mess up your name. And Sandra represents Rutgers Agriculture Experiment Station, and then Beverly Manganelli, who's from Hunterdon Healthcare. We also have our team Chattanooga that's on the call. We have one brave representative today. We have Eileen, who's here representing the United Way, the community partner. We also had Helen Pinkerton, who's from the Erlanger Healthcare System, representing 2 FQACs. And then finally Gregory Heath, who was their data partner from the University of Tennessee Health Science Center. And then finally we have joining us today is Hope Health, who's our team that's from Florence, South Carolina. That's Caitlin Guest, Sonda Jet Claire, Dr. Beeling, who's their CMO, Yvonne Van Camp, and Anita Longan. And that team was made up of the South Carolina DHEC, Hope Health, as well as the South Carolina Primary Healthcare Association. And so what I'll do now is I'll bring the teams on, let them go ahead and unmute their microphones and share a little bit about their goals, because each team had an individual team goal and their patient population. So why don't we start with Hunterdon? You guys are up first. And just tell the audience a little bit about what you guys set out to accomplish through this
Sure.
learning collaborative.
Thanks, Sabrina. My name's Beverly Manganelli, and I'm going to talk a little bit about how we kind of started out with our plan here. And we are in Hunterdon County, which is in central New Jersey, and we do have a growing population of Latinos. We estimate that there's about 1,000 Latinos that have diabetes in our community now. We also have a growing population of older adults, 65 and older, and we estimate approximately 4,900 who have diabetes in our county. These populations have access to an American Diabetes Association recognized program within a diabetes center located centrally in our county. But it's estimated, as many diabetes centers have this issue, it's estimated that only 5% of Latinos with diabetes have taken advantage of this education. And we also have low utilization of our older population. Only about 6% we think are accessing diabetes education, even though they have Medicare insurance coverage for a lot of the education. These patients also have access to many other excellent community diabetes resources in our county, and they include Rutgers Cooperative Extension, Department of Family and Community Health Sciences that offers diabetes support groups, and also some community diabetes programs. We have the Hunterdon County YMCA who was doing a DPP program. We have the United Way, which offered a grant-funded program that aimed at reducing obesity for the Latino participants. And we have Norwest Cap, who offered the DSMP program. We also have local shop rates, which are local grocery stores that have nutrition professionals that offer diabetes programs. So we have basically a wealth of resources here in our community, but underutilization of almost all of them. So what we decided to do was to form a committee. So we asked representatives from each of those resources to join our committee. And we called it the Hunterdon Diabetes Care, and the CARE stands for Community Access to Resources and Education, to address these issues in conjunction with the Partnership for Diabetes Health Equity. So that's kind of, a little background on how we started. But our overall goal was to reduce the disparities in diabetes care and outcomes for Latinos and adults 65 and older. That we kind of came to the conclusion that we bit off a little bit more than we can chew. So ultimately we decided to focus on the Latino population specifically. So again, since we're rich in resources but low in usage, which threatens the sustainability of many of our programs, we wondered if a community-wide promotion of our diabetes services in conjunction with an inter-referral system among those resources, we wondered if that would increase access for these patients to those available resources. So we set out to do a few things. We set out to collect and utilize data to measure the increased utilization of our programs. We asked our partners to begin to determine how to track the use of their resources and cross referrals between programs on a monthly basis and share that data, which was a little bit of a challenge. And we also wanted to track the overall number of Latino patients with diabetes or prediabetes in the county and their usage of our programs. So those are the kinds of things we were looking to do. And we hope that this community clinical collaboration would ultimately result in an increased access and sharing of data about our target population, which might include improvement in A1Cs, in diabetes-related hospital admissions, those kinds of things, and ultimately increase the use of the excellent resources in our community. So I think that's where we started, and you'll hear a little bit later about our successes and challenges, but it was definitely a learning experience.
Thank you, Beverly. Now, Eileen, can you share a little bit about Chattanooga and what your team set out to do?
Sure. Helen Pinkerton with the Dotson Avenue and Southside Community Health Clinics and I had served on the Preventative Health Committee prior to this initiative. And I representing the community piece, and she also informing me about issues around people coming into her facilities over and over again with the same chronic problems, and also the absence of people coming in that possibly needed health care in those zip code areas that she served. We had formed an alliance together through a Building Stable Lives program that United Way has continued to have, and based on my education in terms of the need of people to have the types of care that a medical home could provide, what we did was we incorporated a process by which the people that participated in our Building Stable Lives programs with life coaches, 5 life coaches in target areas, including where her health clinics were, that people would identify a medical home. Now, I find that initially what we set out to do, in my definition, was to change 2 cultures. That was the culture of the Dotson Avenue and Southside Health Clinics, and the culture of the communities. Now, what actually happened was, with her educational program, was she received referrals for people to access education around chronic diseases, including diabetes, and that I would support that in terms of what was going on in the community, including the research that I did that mapped where our food boxes were going, our food boxes from the food bank, which also had a lot of material, a lot of food that was not healthy food, that would change, particularly with those people that were targeted as having diabetes, when they would access food, that it would be nutritious food that would not hurt their disease, that would provide more nutrition around to prevent more preventative measures. So with the mapping and identifying that as an issue, we had decided that we would form the partnership with the community in terms of making that referral for a person with diabetes, educating them at the clinic, and then bringing them to the food bank to get nutritious food if they were identified as having this type of issue, that we would make sure that they got the kind of food that they needed. And we did not get the cooperation from the Chattanooga Area Food Bank, but we did get cooperation from a small local food bank, and they had a retired nurse on staff 4 or 5 days to check people as they came in and made sure that they got a healthy box. But we've moved forward, particularly with the community issue, and I think that'll be described later on. If I go down through the list of goals here, we wanted to, if I go to goal 3 here, particularly reduce disparities in social, health, education, employment opportunities among residents of the targeted population, predominantly African American males, which the statistics are horrific in terms of comparison to the white counterparts, not only their diabetes, but their cardiovascular disease. My part, especially, to establish a sustainable model of community engagement, and I think with future presentation, I'll be able to demonstrate how that was done, to form more preventative types of things in the culture. The culture needs to support healthy outcomes, particularly with regard to diabetes, and that's how I proceeded, was to change that culture towards more healthier outcomes.
Thank you, Eileen. And Anita, can you share with the audience about your target population and the goals you guys set out to accomplish?
Sure, thank you. Yes, so our team was made up of the Hope Health Diabetes Center, South Carolina Primary Healthcare Association, and the South Carolina Department of Health and Environmental Control, known as DHEC. Hope Health is a federally qualified healthcare center serving patients in eastern South Carolina. We have several clinics throughout the state. So, and we offer primary care services as well as specialty services, for instance, women's health, psychiatry, dental, even chiropractic, massage therapy, and it's a patient-centered medical home. So our goal initially was that our team would try to make changes that would impact people in South Carolina with diabetes, with disparities, so those who were underserved, and that we'd be able to improve their health outcomes that were related to diabetes. So in-house, within Hope Health, where I work as a diabetes educator and a dietitian, we wanted to begin by identifying who was most in need. And what we found was that for our diabetes education group sessions, the group of people who had the poorest completion rate were African American men. So that was one of our target populations. Also, our diabetes center is housed in Florence, in the Florence clinic. But as I said, we have several clinics in rural areas where people have no access to diabetes education. So in partnership with the South Carolina Telehealth Alliance, we were able to obtain equipment and provide diabetes education via telehealth for patients in our rural clinics. So that was another one of our target populations. So specifically then our aims were we wanted to improve completion rate for African American men for our diabetes education groups. We wanted to make sure that our patients in rural clinics had access to the same level of services that our patients here in Florence have with respect to diabetes education and medical nutrition therapy. We also offer a lot of community group-based programs too, like diabetes prevention program. We have a program called Better Choices, Better Health. We have, we're going to begin to be offering that program in Spanish as well. And then, not a formal partner in this collaborative, but we were working with the managed care health plans in order to identify our patients with diabetes who had either fallen out of care or who had gaps of care. So, for instance, those people who hadn't had their annual retinal screenings or their diabetic foot exams. So we started offering retinal screenings in-house at Hope Health. And have started taking the camera to our rural clinics too. And then we wanted to share with other DSME programs throughout the state what our lessons learned were and our experiences were.
Thank you so much, Anita. In fact, thank all of you for giving us an overview of what you guys set out to do. I mentioned earlier that we started with the premise that you guys as teams could work together to create a 3-element model of care for patients with diabetes. It will require multi-agency and multidisciplinary partnerships and or coalitions. So then this collaborative, as I mentioned earlier, we focused a lot on capacity building in order to collaborate. So let's talk a little bit about your individual experiences with capacity building and the pain of that change, or as I like to say, the trauma and the drama. So Team 100, why don't you tell us what you learned about the way you guys, the way your collaborative functioned that speaks to capacity? Like, what were your challenges and your successes with that?
This is Sandra. Sandra Grenfield, the switch. Yeah, wow. I've become Bev.
Beverly, you changed. Hi, Sandra. Welcome. Tell us a little bit about the organization that you represent.
I work for Rutgers Cooperative Extension, Department of Family and Community Health Sciences here in Hunterdon County. I'm a registered dietitian and diabetes educator, so I have a great interest, obviously, in really promoting community-based diabetes resources as well as the traditional clinical resources. So I think I would like to start with, if it's okay, with our successes, or would you want me to start with challenges?
Well, I can go here and then remind me to go backwards.
So I think definitely when we started our diabetes care collaboration, we started with about 7 organizations that Beverly mentioned, and we all work in Flemington in very close proximity to each other, but rarely did we work together. There was really very little collaboration prior. And when we started meeting regularly as part of the Learning Collaborative, we really learned a lot about what each other's programs involved and what each other was doing. So it really did improve the communication among all the organizations that are offering diabetes services in our county. And what we were really hoping to do was to increase the access. So really, to increase awareness of all these great resources, as Beverly mentioned, and also to refer between each other. So for an example, when patients are fortunate enough to come to the Diabetes Center for more formal diabetes self-management education, often they have limited insurance coverage and limited visits, but we have these great community resources which can help them after they've had their initial education. So, for example, I've been facilitating 2 diabetes support groups in the county. And one of them in particular would not have happened except for the new collaboration that we are experiencing with one of our supermarkets in the county, in the northern part of the county. I really wanted a second location to reach out to areas that are not in the immediate Flemington area. And by partnership with ShopRite, we have developed an ongoing site for a second diabetes support group, and it's flourishing. That wouldn't have happened before we actually met regularly and learned about what each other was doing. We also sort of came out of our comfort zone a little bit and tried to reach individuals and potentially new partners to help us better serve the emerging Latino population in Flemington and 1 or 2 other areas in our county. So we increased our communication with those groups, those stakeholders who are serving those populations. So we had originally 7 key member organizations, and we added 2 more. One of them being the United Way, that serves, of course, the underserved and the Latino population here in Flemington in Hunterdon County. And the other was the Hunterdon Helpline, which we did not know could really be a great referral service for us, for all of us in the county. So I guess, to summarize this slide, we really learned about what we all did and what we could all offer, and we expanded our opportunities for collaboration. So it was a little bit more challenging than we thought it was going to be. I think, in a nutshell, maintaining momentum of a diverse group of organizations can be really difficult. And some of the things that we observed were, staff turnover, for example. So people who had been coming regularly to our meetings, all of a sudden they were in other positions, and we had to sort of start over, if we were lucky, in having another contact from a particular organization and having them come regularly to our meetings. We found it was difficult to maintain momentum because things happen in work and with each organization. And if this is can be a shifting priority for different organizations and for individuals. So it was difficult to keep the momentum going in some of our initiatives. I think, in particular, we needed to keep developing a better handle on this shared vision that we had. While we all agreed that programming was important, sometimes it was difficult to nail the higher vision and to have people work towards that. We also experienced quite a bit of trouble in really reaching the Latino population, and we discovered we didn't have the right people really at the table. We were looking for more contacts in the community, people who work directly with this target population of ours, and we were not quite as successful as we had hoped. Part of that was also due to the fact that we had very little data on the Latino population in particular, and especially when we're talking about the diabetes situation in the Latino population. We just didn't have any reliable information or local data. So those were the main challenges that we experienced, and but we did overcome some of them. We were successful in really running some brand new collaborative programs, and I described a few of them on this slide. One of the things that we were successful in trying to get information was to hold our first focus group with the Latino population. So we think that we learned some important things about how this population views the traditional medical system in our county, and possibly we're not as prepared to serve this population as we originally thought. So we have a long way to go, but it's been a very interesting experience.
Thank you, Sandra, for sharing with us. Now let's move to the Hope Health team and have you guys talk to us. Oh, actually, no, we're doing Chattanooga. Okay, I had that in the wrong category. So, Eileen, you were the community partner that's represented on this team. And I will not forget the very first time I met you in person, how you showed up for our in-person training, and you were a bit bothered because you felt like as a community partner you did not need to be at the table. What in the world does a community partner have to say or do about the health of these people with diabetes? So please take a moment and share with the audience your experience and just the wonderful springboard that was to what you're currently doing.
Well, I have lots of thoughts about this, and I don't know if I think what happened initially was we thought there was a simple process. We have our 211 information referral system. So somebody calls in for help and they need food. So we could ask a simple question if they have a medical condition, something we were trying to figure out, something simple that we could ask to identify that individual and then provide them with a healthy food box when they call. At the same time, Helen Pinkerton with the community clinics, and I have to pitch in a word for her. She's really moving things, and it takes forever. You've got it exactly right. You ask people to do something different, and it's very, very difficult, to get that implemented and continued, that process to continue. But she's moving forward with an educational piece to help people understand what they can do better with their lifestyle to manage their disease. So I give her credit for that. But then we thought we had this simple process by which not only we could measure the disease element, and you have a term for it, I always get it, it's A1C3, something like that, but that would be able to be measured with the UTC epidemiologists, and then turned out the IRB fell through, so we couldn't do that. But so we had this simple process where they would come in, they would seek help, we'd identify them as diabetic, they'd get a great food box, they'd get the education, and then we would be able to see the results. Well, we did have obstacles, but out of this, I have to say, the relationship that we developed is so important. Prior to this work that I've been doing, and we're a small United Way, we're not big. Health sort of fell off the program. We didn't talk about health. And then the work that I've done and presented to the allocations committee and presented to my superiors has educated us all here at United Way. But the issue is that also with that, we have a personal relationship whereby just recently, I'll give you an example. You know, you take this, it's individual by individual and community by community. But Helen had one individual in particular, a young man, and she told me, the dental issue is so serious in terms of this disease. And this young man had a condition by which all of his teeth had to be extracted. And he had no job. He couldn't go get a job because of the condition of his mouth. So she appealed to us, and we were able to fund this person. It hasn't happened yet, but he's going to get the money not only to get his teeth pulled, but to get dentures as well. So that closer relationship is going to work more and more on an individual basis, person by person. The map that you're seeing, when we talk about food, how important it is, those areas, if you look at the map that says where diabetes is, that's where our food boxes are going. So how can we use the food boxes as an educational tool? And the food bank initially was not on board, but now Feeding America is changing its mission. So we're less about pounds now and more about nutrition. So I expect that's going to change as well, and that we helped raise the issue, raise the awareness about that. I was able to show not only where emergency food requests were, but who was providing those food boxes. And it was the churches all throughout this area. So what we did, too, was try to educate the churches. Anyway, the 2-in-1, the other piece was the Building Stable Lives piece, where we have 5 coaches in these zip code areas that we're saying are not only target areas, but where the clinics are located and where the food boxes are going. Now, I'm going to tell you what happened there was that we really wanted to press the health issue with our Building Stable Lives coaches that we fund in these neighborhoods. And this is what the resistance that I got and the education that's needed throughout it. So we're changing 2 cultures. I think we're changing a professional culture as well. I was told that health is not something that they can deal with, that they have all these emergency needs, and that they can't possibly address health in terms of, you know, encouraging them to get a medical home, not do this emergency room care for a chronic disease. Well, interestingly enough, we also do something called the Duke Health Assessment, and what it showed was that a high percentage of the people that were participating in our Building Stable Lives programs not only had issues around health, that was connected to issues around mental health. We could find a correlation to that, and also to self-esteem. Now, what you're talking about is people we're trying to help get jobs, get employment. So this affects so much, and so then you're looking at lack of employment, you're looking at they can't get housing because they don't have money. You know, it's a vicious circle. And this is what I said to the Building Stable Lives coaches. If we don't address health, you're going to be in business for a long time getting people with all these crisis issues. So this is one of those root issues, access to health care, and something that we've cooperated very intensively with Helen. And again, working with people, trying to get to change their practices, hammering away at it. We will continue to do that. We have that kind of relationship now. The other thing was this, like I said, the churches were providing food vouchers. We are rich with churches. We have hundreds and hundreds of churches. I've mapped all the churches, and it's a map. They're just spread all over the place. And they want to do the good thing. They want to provide a food box. Well, we had a conference. Chalmers Center from Covenant College came down. 240 people showed up, not all churches. It was called Faith, Work, in the Church. And the topic was When Helping Hurts. And I did a breakout session there. It had big maps and everything of all these risk factors. And the question is is the handout, the food that you give, and everybody admitted, when people come to collect food for the needy, what they do is they look through their cupboard and figure out what's expired, or, it's not necessarily healthy food. So to raise that consciousness, and also for the churches that are providing resources for people to get food, is that all that needs to happen? So, or isn't there something else that can help people become more self-sufficient? And one of those issues that came up was health. So out of that now, I am producing an environmental scan for a church that has a dynamic leader. Just bought, as a matter of fact, had to expand his church, so he bought a Kmart that went out of business, bought the whole Kmart. Half of it's gone for early childhood. And he's going to do outreach in one of those neighborhoods that Helen serves. And they're calling it Purpose Point, their health initiative. And what I'm realizing here is in terms of health, in order to change a culture, you need to build relationships. And hopefully, and I know that's what this church is going to do. They're going to build the relationships and also provide those types of resources that help support what it is that the clinic is doing, including they're already addressing nutrition. They're purchasing, they can get food from the food bank for so much per pound, and they're getting fruits and vegetables to distribute. And I know that they'll do more around that. They want to do more around wellness and exercise, that type of thing. And so they're calling it the Purpose Point Health Initiative from the Mount Canaan Baptist Church. So I'm working on an environmental scan.
Eileen,
can I? We'll get out of that too. Yes. Go ahead.
Can I interrupt you just for a moment? Now is a good time for our audience participants to send us any questions that you have, and we can probably answer one or two as our presenters are wrapping up. We were going to wait to do we will have a little bit more time for Q&A towards the end. And so I thought there was a question that was submitted. I see it's disappeared though now. So if you could just send those back, and then Eileen, if you need to share one more thing, you can take like a minute to do that.
Sure. And again, I'm the mapper, but I got this from the health department, and where the little stars are, that's where Purpose Point will be working. The red areas are the areas, it's called an Urban Health Index, a number of factors. And again, the diabetes issue is one of many factors that contribute to the continuation of chronic health disease. And a food desert, that they're going to be operating within a food desert that's the same area where we're having high levels of diabetes, high percentages of diabetes, where the lack of nutritious food is evident because it is a food desert. And I think that might be it. And Dodson Avenue Community Health Center is in that neighborhood as well. So we get the church working with the health center. We got the relationship piece, and to build that community in terms of practices that support a healthier outcome.
Okay, thank you, Eileen. And before we bring Anita on to do her presentation, there was another question that sort of, two questions that seem to be hitting on the same thing, and it's about navigating these challenges for team building. So both internally and externally, and I think initially it was targeted towards Sandra, and talking about making these partnerships with external organizations. What specifically have you guys done, or maybe one thing that you guys have done that helped to get people on the same page and be able to work together around a common goal?
Well, I think our having obviously regular meetings is helpful so that you don't lose the momentum that Sandra was talking about. For us was one of the ways we looked at. Maybe it's not exactly team building, but keeping on the same page, with our participants. But we have to admit that this was probably one of the biggest challenges. That as with any group, sometimes when you're working full time, it's not the priority. This group wasn't the priority. Sometimes we had people that could not spend the time that was needed. So it was. We also are looking at one of our next steps is to send out a brief Survey Monkey on looking at the value, what our team sees as the value of our committee. And I think we do need to step back and, take this and do this survey so that we can really regroup and see, where the important things are. Because, again, we've had some more changes. Our DPP program is no longer in existence. And, now that changes the dynamic of our group again. So, yeah, it's a challenge. It's definitely a challenge.
Okay, thank you. And let's bring Anita on as our time is quickly escaping. Anita, share with the audience your reflections having participated, and then some of the lessons learned that you guys had there at Hope Health.
Okay. Well, we certainly had our share of challenges, and we learned a lot. I think one of our most significant challenges was that there was a lot of staff turnover within our partner organizations. So we would feel like we'd get 2 steps forward and 1 step back. Having said that, though, we've really been able to establish some solid relationships, especially with the DHEC staff, and we've been working very closely together on promoting diabetes prevention programs throughout the state. Another issue was we had full intentions of comparing outcome data, comparing our Hope Health outcome data with hopefully we thought other DSME programs throughout the state or with the South Carolina Primary Healthcare Association, but as it turns out, it was like trying to compare apples and oranges. The data just wasn't there. But we know now what we need to do and work on. We had technological problems, so in-house at Hope Health, the EMR that we were using when we first started out with the collaborative was not user-friendly, but the good things that happened were we now use a different EMR that's much more user-friendly for running the reports that we had hoped to run, and we were super fortunate to add another team member, a dietitian who was working on her MPH and just loved data crunching. So she came in and did a lot of work on the collaborative for us. We had some telehealth equipment problems when we first started out, but that's been resolved as well. So, of course, that's the way it goes with technology, right? So, although, whoops, wait a minute. Okay, PDSA. So, of course, we always are trying to do better in serving our patients, and we have general ideas of what we think they need or what changes we think we need to make, but working on the rapid cycle PDSAs really forced us to hone in on exactly what was happening. So, for instance, with our completion rate for the African American men, it turned out that a big barrier was lack of transportation. So we were able to then get gas cards so that these men could finish their classes. We also, of course, the telehealth program enabled us to provide diabetes education for many people who otherwise just would not have gotten it. I mean, those clinics are an hour away from where we're situated. And for some people, not just the transportation, but taking that much time off from work just wasn't an option. Mm-hmm. So that made a big difference. The other thing is that we've added a population health department, and we've added standing orders for referring patients who have A1Cs over 9%, or those folks who have gaps in care, like they haven't had their retinal screening or their diabetic foot exam. Those people are now being automatically referred to our nurse practitioner, who only sees patients with diabetes. She's part of our team now. That's another development. And then she, in turn, refers the patients into diabetes education. That's made a big difference. The Primary Healthcare Association got us on the agenda in 2015 for the South Carolina annual Chronic Disease Symposium, so that we were able to share our experiences with starting the telehealth program for DSME, because that was the first time it had been done in the state. And then in collaboration with our other team members, and we borrowed, I'm saying borrowed, not stolen, the idea to come up with the prescription pad. I don't know if you can see that, but it seems like a little thing, but we're really excited about it. So it lists all the programs that we offer, and the primary care providers are going to be able to use that to encourage patients to come to our programs. So, and then the other thing is, I was just going to also mention that our goal is to achieve recognition, NCQA diabetes recognition for Hope Health.
Awesome. Thank you, Anita. We do have a little bit time now to entertain questions. I know there was a question that talked about, that asked about the EMR. We have another webinar coming up next Wednesday, and one of the teams that's on, they actually ended up purchasing something to sort of plug into their EMR that allowed them to do referrals to community-based organizations. I know that our Chattanooga team, the FQHC, has gone to Epic. So, Anita, are you guys using Epic as well?
We've just switched to eClinicalWorks. And compared to the EMR we were using, we really like it.
Yeah. And the Dallas team, which will also be on next week, they also use Epic, is what I believe. So I hope that answers the question. There was another great question from Dr. Dowd. Hi, Dr. Dowd. That talked about, making sure that our patients with diabetes are getting all of the referrals they need. And so we talked about dentistry, which I was very excited to hear, as well as vision, but her question is a good one. What about podiatry? And then I know many of you are addressing the pharmacy needs, so can one of you share, Beverly or Sandra, if you'd like to share about if any of your community partners is helping with pharmacy needs of the patients?
We don't, right now, we don't have anybody addressing the pharmacy needs of the patients. What we do have is an annual dilated eye screening that we run with the New Jersey Commission for the Blind, and usually in October or November, that serves about 70 patients. They come in and they, get their dilated eye exam. We have a small health fair along with it, and we do make sure that it's really for the underinsured or uninsured that they do get that kind of service. Pharmacy we really haven't addressed at this time, though.
There was another question that came in. That's a nice comment, Dr. Holloway, and I'll get to it in just a moment. I particularly was thinking about Eileen for this question of non-traditional partners that, from you being United Way, to me, when I think United Way, probably before I met you, I did think more like housing needs, so that would be immediately what I would think about. And not necessarily thinking about health. I know you mentioned health coaches. So the question is about non-traditional partners. Has anyone had success with non-traditional partners? Transportation often comes up. And I remember, I think it was you guys in New Jersey that had issues with trying to get a clinical partner that could cross, a transportation partner that could cross county lines. Was that you guys? So can any of you share about getting non-traditional partners to the table?
The issue is that all these things are related. So the housing issue is about neighborhood. I see there's one question about violence, public safety, affects physical activity. The housing issue is, what we did was we had legal aid in the hospital, to provide services, and it turned out that the service was used mostly by women with children with asthma, and they were also evicted because they complained about black mold in their housing. So, for me, basically, it's where you live. So whether you have transportation or whether you have adequate housing, or if there's domestic violence issue, there's a lot of things that affect health and mental health. So all those things are interconnected for me.
That your point is well taken, and that brings up the importance of doing the social needs screening. That of we have some best practice ideas around that, implementing the social needs screenings, because patients are accustomed to answering questions, and so our staff needs to get comfortable with asking them those kinds of questions that affect their health. And so that's a way to identify, but it would be helpful to have a partner that you can refer them to once the need is identified.
We do have the 2-on-1 system. So, and that has all of the resources that are available. So we have partners, we partner all the time. So, Chattanooga Housing Authority, the churches, medical, we have a whole list of social services that we refer to.
Mm-hmm. Awesome. So the takeaway from this webinar is United Way 211 should become a partner for all of you clinicians that are listening. So, as well as the YMCA, I think there was a question that came out about making a partnership with the YMCA. YMCAs across the country now are implementing DPP classes, so for those of you that need a resource for that. But many Ys also do other health and wellness kinds of programs, and they tend to have special programming for patients who are indigent. They complete an application, of course, but they may qualify to attend those classes and or be able to exercise at a reduced rate and sometimes free. So the YMCA also is a really good partner to bring to the table. So I did want to let you guys know that for those of you that submitted questions through your registration, as well as those that we didn't get a chance to get to today, that we can have those answers written and we will have them on the website. I do need help advancing the slide now. I'm sorry, IT, I'm messing up now. I can't see how to advance it. But I also wanted to remind you that next week, Wednesday, we have part 2 of this webinar series and talking about this learning collaborative and some of the exciting things that our teams came up with. I have been told to remind you that we have scheduled a Twitter chat. So in an effort to keep the conversation going, we're going to have a conversation via Twitter that will take place on, I think I have a slide here someplace, or maybe I don't. But on June 28th, I believe that we will be having a Twitter conversation, what is it called, Shirley? A Twitter chat, not a Twitter conversation. I guess you guys know I don't do the Twitter thing. And we also have some resources on our website. We will publish a report, an official report of all of our findings and the things that the teams did, and that will be available next week as we conclude the webinar series. So we invite you to go to diabeteshealthequity.org so that you can learn more about the offerings as well as the conclusions of this project. And with that said, I have to bid you a good afternoon, and we hope to see you back next Wednesday at 2 p.m. Eastern Standard Time for part 2. Thanks very much for attending, and enjoy your afternoon.